Hello, thanks very much. What key features in clinical and bedside assessment are important for your risk assessment in this patient?
Key feature on clinical assessment
Yep.
and bedside assessment. So this is a significant sort of life-threatening calcium channel blocker potential toxicity, already evident by heart rate of bradycardia, so she's already under the toxic effect of that. So I just would like to do the fact that she is intoxicated with altered conscious state. This is a challenging situation for me because this patient with altered conscious state, we need to protect her airway as well. The fact that she's already vomited and there's alcohol on board is going to make my airway management and intubation an extremely difficult situation, as well as the hemodynamic instability, which I anticipating as a result of valvular overdose. So I just would like to do my risk assessment and check how much she had, the time of the ingestion, and also if there's any co-ingestant as well. I just would like to know about her past medical history and what sort of symptoms she's having so far. As we can see from the assessment, she's already bradycardic, borderline blood pressure, so she already shows signs of toxicity. And for the investigation, I would like to have an immediate ECG, venous blood gas, full blood count. I need to check her urea and electrolytes as well. And at the same time, I just want to make sure that her BSL, need to check her blood sugar as well.
This is the patient's 12-lead ECG, taken 10 minutes after arrival. Describe and interpret the findings.
So as we can see, she has got severe bradycardia with a rate of 1, 2, 3, 4 times 6 with a rate of 24. She already have a blood complex. She shows sign of complete heart block. The PEES is not communicating with the QRS. So in a context that's significant calcium channel toxicity, need immediate attention with graded escalation of the management. So I just would like her to be in a resuscitation cubicle. Can we talk about management?
There, let's go on to that. Describe your prioritised management interventions. Assume you are the team leader.
So I will need to, I'm the leader. I need to assemble my team. She needs full physiological monitoring. I will allocate a person to look after her airway. So general management, specific management, and supportive care and disposition. So in terms of the resuscitation, she's definitely need to have fluid bolus to address her blood pressure. It's currently 100, but I'm expecting to get worse. My aim is systolic blood pressure 100 systolic, and she's currently bradycardic. I would like to give her atropine. I'll start with 600 mic up to 3 milligram. I don't think so it's going to be beneficial, but then my next plan will be start off adrenaline infusion. I'll start her with 6 mic per minute. My aim is just to have a heart rate of 60. If that's failed, then I will consider transcutaneous spacing. I'll follow it by transvenous spacing as well if that's failed. But for temporizing measure at this stage, I just would like to give her the atropine, the adrenaline, and then take it from there, assess the progress after that. Now, for the antidote, I would like to give her calcium gluconate. I'll give her 60 ml of 10% of calcium gluconate. My aim is serum calcium more than 2 millimole per liter. Or 2 millimole, sorry, the concentration of the calcium. With the blood pressure, repeated boluses, if not effective, then as we said, we start our anatrox adrenaline infusion, and with the parameter of urine output more than 2 mils per kg per hour. And then I escalate to we given the antidote, we given the fluid management, this patient, and then I need to decontamination. After I protect the airway, I should do this earlier, give her 50 grams of activated charcoal after I'm sure that the airway is protected. Now, with the intubating, this lady is going to be a very challenging situation as well. I need to make sure, because she's A, hemodynamically unstable, B, she's not fasted. I've got physiological difficulty with that as well. So I want to make sure that the most experienced operator doing the intubation, I need to have all my airway equipment. I will anticipate difficult airway due to physiological issues. I need to have a double setup just in case if I have failed intubation, and I will be ready for Chico situation, can intubate, can ventilate. I don't think so that will happen. She's 35. I don't think so. We have to
What drugs would you use?
So I will use less hemodynamic effective drug. I will use ketamine. She's already intoxicated, so I'll give her 1 milligram per kilogram. So probably I'll give her between 50 to 100 of ketamine, a little bit of fentanyl, and then I can give her Sax 1.5 milligram per kilogram per body weight. So about 100 if she's. So that's my intubation plan.
So just list what other treatments might be useful, especially if the patient remains bradycardic hypotensive. What other treatments?
So we've talked about transcutaneous spacing, that can escalate to intravenous spacing, and then I could escalate to intralipid, 20%. I have to check the dose.
Yeah.
I need to discuss with the clinical toxicologist, probably intra-aortic balloon pump or ECMO if I have the facility.
What other therapies are useful in calcium channel blocker overdose?
Dextrose infusion, I should mention that earlier, but I forget about it. So I give her 10 units of atropate, which is 0.1 unit per kg, and also dextrose 10%. IV push, and then I can give an infusion as well.
Tell me the dextrose
So,
dose that you use.
I can use 50% of no, that's not okay. So dextrose, yeah. So 10 mils of 10%. Sorry.
Thank you.